something just happened. I got a call from a patient I saw, I think, a week or two ago. Left a message, Kelly responded. Usually you don't call here because the people here don't have access to the medical records. They're all through the electronic medical record at USF. But it was a patient that has a very common problem, complex motor fluctuations with dyskinesias. In simple language, it means that when they take Cinemet, Cinemet increases the amount of movements. They're involuntary movements. They can be dance-like or twisting, turning movements. And when they're mild, they're okay, but they get pretty bad and they're upsetting to everyone. And then there's a period where he has a dyskinesia and still able to function, and then he starts wearing off pretty quickly, and then next thing you know, he has a combination of dyskinesias, tremors, and rigidity, and then he's off. And this repeats every 3 hours, right? 50% of the patients develop dyskinesias on levodopa. That's why anyone less than 60 who has Parkinson's disease, we like not to use levodopa, because levodopa, or Cinemet, is the major cause of those involuntary movements. Levodopa is a double-edged sword, as all the anti-Parkinson drugs are. It alleviates slowness and rigidity, and alleviates tremor in many people. And it works well for the first 3 to 5 years, beautifully, without much wearing off. In other words, 3 tablets a day will cover you for most of the day, but with time it covers you less and less, so you have to take it 4 times a day. Maybe Comtan is added on. But some people, say about 50% of the people, will eventually develop a little extra movement that they don't mind because it means the drug's working. So they're looser, and you'll see them doing like this and moving loose. That's called dyskinesia, from the Greek, abnormal movement. Kinetic is movement, something kinetic, dynamic. So what happens is, though, and a subset of those that develop dyskinesias get severe motor fluctuations. And it's that up and down roller coaster ride that is the #1 reason that people end up having deep brain stimulation. There's the electrode put into the subthalamic nucleus, and you have a pacemaker. Well, this person that I saw 2 weeks ago had a pacemaker, had it done up north, and was having still severe fluctuations, needed to have the adjustment of the pacemaker as well as adjustment of the medicines. So even with the pacemaker put in place, people sometimes have very severe motor fluctuations, and they were looking for someone who does the adjustments of the pacemaker. Now, I personally don't adjust pacemakers. It takes certain training to do that, and usually it's a person who does the surgery has a team member, a neurologist or a technician that does the pacemaker adjustments. But what I usually do is adjust the medicine so that there's less fluctuations. In fact, anyone who has those kinds of motor fluctuations, I will do my utmost to solve it with a schedule of medication so that they don't have to visit the surgeon. So what I did with this patient is, as many of you are familiar with my approach, and the approach of others who are experts in this field, is to use a dopamine agonist, that's a synthetic dopamine, kind of like Mirapex, or Pramipexole, like Requip or Ropinirole. The new form is one that you can get through the skin. It's called Nupro, also known as Rotigotine. The beauty of that is that it results in very constant blood levels of the agonist, which in turn results in constant stimulation of dopamine receptors in the brain. When you have that kind of action, you don't have motor fluctuations. Motor fluctuations reflect the ups and downs of the orally delivered levodopa and orally delivered dopamine agonists. So my first thing that I do when I see people with complex motor fluctuations, get them on a long-acting dopamine agonist. So you got it on. You start with 2 milligrams the first week, 4 milligrams the second week, 8 milligrams the third week. And I write down, if you develop any worsening dyskinesias, because that's what happens, because when you add dopamine agonist to levodopa, they potentiate each other. Everything gets even greater. So, but I don't know at what point you cut back the Sinemet. So the goal is, the way I do it is this, and I write it down for the patients, and I want everyone to pay attention, because I don't like the kind of calls I get back if you don't pay attention. And the reason I get calls back is because they haven't paid attention. Here's the number one thing. As you take a 2 milligram dose of the patch, and you're taking 2 tablets of Sinemet 4 times a day, you may end up getting worse dyskinesias initially. So what do? You don't give up on the patch, you cut down the Sinemet. That's the thing you can adjust. So you cut it down maybe to 2, 1.5, 2, 1.5, depending on when you get the dyskinesias. After a week, you go to 4 milligrams of the patch, and you get even worse dyskinesias, well, you cut the Sinemet further. You turn down the volume on the Sinemet, you turn up the Nupro. And finally, after the 3rd week, you get to 8 milligrams, you're going to get worse dyskinesias or not, depending on how much you cut back in the previous weeks. And so theoretically, this person could be on 1 tablet in the morning and a half tablet every other time with 8 milligrams of a patch. And let's see how you're doing with that. If you still have severe fluctuations, then we will go to get your tuning of your transplant, of your pacemaker. So this person had gotten to 4 milligrams of the patch, called last week and said, oh, I can't take this. My dyskinesias are worse, I have headaches, I have this. I said, don't you remember what I asked you to do? He says, well, no. I said, I asked you to please, if you have any side effects, like worse dyskinesias or like anything, it's due to the combination of Sinemet and the Nupro. It isn't just due to the Nupro. So, well, why am I getting it now that I added the Nupro? I said, don't you get it? You're adding 2 things that act on the same system. Oh, so cut down the Sinemet. And then once you see that you're on the whole time without dyskinesias, you could stay there. 4 milligrams of the Nupro and 1.5 tablets of Sinemet 4 times a day. But if you still have uncomfortable fluctuations, you increase to 8 milligrams. Usually someone in this stage needs about 8 milligrams of Nupro. And the amount of Sinemet has to be adjusted per patient. After that's done, and if there are unsatisfactory results, that's when I call my colleague, the neurosurgeons, to evaluate the pacemaker, to set the stimulating parameters. And if they don't have the pacemaker, maybe they should consult with a surgeon. So the reason I'm telling you this, 3 calls from the same patient, mostly from his wife, who was there, who I thought was also taking notes, besides the notes I gave them. And they didn't understand what the strategy was, and I spent an hour with them. And then they called a few more times. So that's not, something's not right. I'd like to think it's not my fault. Something has to be done so that patients learn this. So that's why I'm telling you this. Now, this is just one person out of 100 that I'll do this regimen with. And only every now and then some people just don't listen. They just don't get it. So that's why I was just frustrated because I had another call. I was driving in through the rainstorm. Kelly says, oh, Mrs. So-and-so called again. Same issue. And then I get a note on the desk here. Mrs. So-and-so asked, it's very urgent you call. So the patient is her husband. So I call Mrs. So-and-so, and Mrs. So-and-so is out somewhere. Her husband, I could hardly hear him. He finally was able to articulate the problem to me. And he admitted that he didn't quite understand what the strategy was. And this is several phone calls after. And unfortunately, I didn't get to tell his wife the same thing. But believe me, there'll be another phone call from her because he said, I'm going to have her call you. What's a good time for her to call you? I said, don't call me. We've been through this. Maybe she's here. Is Mrs. So-and-so here? What she wanted. Anyway, so it's very frustrating because it shouldn't be. There's so many worse things that we can have to deal with. And I'll tell you what the next common problem is that is a little more troubling. I think this complex motor fluctuations with worse dyskinesias can be adjusted by judicious rearrangement of the medications. And we can do pretty well until we need to call in the surgeons. And I have a good track record at not sending my patients for deep brain stimulation. Because by the way, not everyone develops these very serious complex motor fluctuations. And I know that when I was in England, they were amazed that many of the neurologists there, you Americans seem to have a lot more problems with motor fluctuations and dyskinesia than we do. And it's because we are very quick to slap on levodopa, carbidopa, as soon as the diagnosis is made. And what is likely to produce dyskinesias? Well, if someone has the illness at a young age, say 30s, and starts receiving levodopa, carbidopa right away, and then taking it, increasing doses with increasing frequency, those people get the worst dyskinesias you can imagine. Sometimes the dyskinesias will appear within a year of treatment in a young person. So when we have a young person who's diagnosed with Parkinson's disease, who needs symptomatic relief, we tend not to use Sinemat or levodopa, carbidopa. We'll use a dopamine agonist. Ideally now it's the patch, because if you start off with an agonist, you're less likely to develop dyskinesias. However, if you're over 60 and you're recently diagnosed and you need symptomatic relief, we'll use levodopa, carbidopa, because people are less likely at that age or older to get severe dyskinesias. They can get mild dyskinesias, but they're not usually so severe. So that's why we have this rule of thumb of who should get the levodopa first. It depends on age. Now, the other factor that determines the development of dyskinesias is the rapidity of onset and rapidity of wearing off effect, and the immediate action. So something like levodopa regular, it reaches a peak within an hour in the brain, and then it wears off very quickly. And that kind of pulsatile administration seems to have a role in the development of these dyskinesias. Then another factor is the pattern of dopamine receptors that are activated. So levodopa converted to dopamine acts on 5 different dopamine subtype receptors. The way to kind of explain what I mean by a drug and its receptor, it's really a neurotransmitter and its receptor. Dopamine is like a key, and it fits into a very specific lock. The key of dopamine won't fit into other locks. So dopamine fits into a lock, allows you to open the door and walk out freely. So that's how it is. But there's 5 different types of lock, subtypes of lock, that dopamine works on. Dopamine can open about 5 different, they're called D1, D2, D3, D4, D5. The D2 lock is the most important one for movement. Now, dopamine agonists, synthetic dopamine, can be made so they have preference for one subtype over another. So this drug Pergolide, which is no longer on the market, was a dopamine agonist, fit a D1 receptor. And it was wonderful because it alleviated the slowness and rigidity, but it didn't ever cause dyskinesias. And that used to be my go-to drug for preventing dyskinesias. We don't have a selective D1 agonist anymore, but I'm hoping that the drug companies are working on it. So yeah, the other major problem that comes up, and then I'm going to take questions from the floor, that is troublesome, that every person who works with Parkinson's disease experiences, is this issue of insomnia at night, frequent awakening to urinate, and vivid dreams, acting out, and or hallucinations. So all these non-motor issues. I talked about the motor problems as being difficult, but the non-motor issues of insomnia, frequent awakening, vivid dreams, acting out, and visual hallucinations, to the point that the hallucinations seem very real, and delusional thinking can develop. So that used to be one of the major, this visual hallucinations, paranoia, and delusional thinking occurs in about 25% of patients sometime in the course of the illness. The risk factors for that is more advanced age when you have the disease, problems of severe insomnia, and cognitive decline. All of those three things tend to enhance the production of visual hallucinations and delusions and paranoia. Fortunately, we now have a way to treat it without having to do the old way, which was called, quote, drug holiday. Many of you may have heard that term. In the past, whenever a patient would develop these visual hallucinations, paranoid delusions, acting out of dreams, we thought it was a toxic effect of Cinnamon. And we would admit them to the hospital and stop all of the anti-Parkinson drugs, almost as if it was a poison that we were removing from them. It was a detoxification or a drug holiday. So people would be in the hospital for a week, completely off a drug, and you can imagine what would happen to the patients. They become extremely rigid, immobile, and very unhappy with that status because they couldn't move. And the complications were big. They could develop pulmonary emboli from not moving. They get clots in the leg and they go to the lungs. And they could get a malignant hyperthermia. And the only reason that finally stopped, because that was when I was beginning to train as a movement disorder specialist in 1985, we were still doing that. We would admit patients to the hospital and detoxify them. And the goal was you get them free of all the Cinnamon, and then when you reintroduce it at a lower dose, that lower dose was starting to work again without the confusion. So you'd send them out with a somewhat lower dose. But after a while, that lower dose didn't work anymore, and they kept on gradually escalating and ended up in the same place. So the reason that it's not done anymore is twofold. Number one, insurance companies refuse to pay for the hospitalization for detoxification, because they said this isn't a toxicological effect. This is not. It has a lot more to do with the patient's the brain than with the drug. Secondly, we developed, the drug companies came up with novel neuroleptics. These are a new class of tranquilizer drug that would prevent hallucinations and psychosis and are wonderful for sleep. And that now allows us to introduce these two drugs. The first one was called Clozaril, which was like a miracle drug because it allowed people to sleep through the night. You just gave it at night. They didn't have hallucinations. They became clear in their thinking. They're not perfectly clear because if they were demented, it wasn't an anti-dementia drug, but it certainly would make them aware of what's going on and sleep well and not have to cut way back on the Cinnamon. Because one of the things you did when people did have this side effect of hallucination was to cut way back on Cinnamon, which helped a little bit but didn't completely eliminate it. But with Clozaril, which was originally developed as an anti-schizophrenia drug to treat delusions and psychosis in schizophrenics, when it was first used in Parkinson's patients, the main reason it was being used was that it didn't block dopamine receptors. Most of the major tranquilizers that we use, the old classical ones, are dopamine receptor blocking agents. So knowing what you know about the importance of dopamine for promoting movement, imagine something that blocks dopamine, what it's going to do. It's going to produce Parkinsonism. It's going to worsen Parkinsonism. In fact, many of you already heard the history. How we learned about dopamine in the 1950s, that decade of the 50s, was the observation that the major tranquilizers given to young schizophrenics, I'm talking about Thorazine, Haldol, produced Parkinsonism, a Parkinson syndrome in young schizophrenics. They looked identical to Parkinson's disease, except they were in their 20s. They shuffled, they drooled, they had little diminished facial expression, didn't swing their arms. And the study of how these major tranquilizers produced Parkinsonism led to the insight that there was a deficiency of dopamine in people with Parkinson's disease. And it wasn't caused by a drug. It was for unknown reasons that the dopamine neurons began to lose their ability to make dopamine. So you see how the insight into the dopamine basis for slowness and rigidity came from the study of the major tranquilizers. So We couldn't use those major tranquilizers to treat psychosis and Parkinson's disease. Now you understand why. If someone had hallucinations and confusion and they looked just like a schizophrenic, you couldn't use the anti-schizophrenia drugs because it would just produce Parkinson's disease. So better to stop the levodopa, put them in the hospital, and let them get Parkinson's disease all over again. Oh. Right? It's better than giving a drug that gives Parkinson's disease. So you understand the logic for the drug holiday. Now, what the new tranquilizers have done was allow you to give a dopamine, a tranquilizer that doesn't interact with the dopamine receptor. It acts on a serotonin subtype receptor that mediates hallucinations and psychosis. So Clozaril was like a miracle drug. I began to administer it in around 1990. The problem with that Clozaril or clozapine was that it required frequent blood tests. Every week, one had to get a complete blood count because there is a slight but real possibility that they could develop an anemia from this drug, aplastic anemia. It could be fatal if you weren't aware of it. That's why you had to every week monitor the blood, and that was a real drag. You couldn't get any of the drug until the blood count was back and showing that you can tolerate it. I still have one patient still that's been on Clozaril for 15 years, and but we still do the blood test, but now it's every month instead of every week. She's never developed. I've never seen anybody develop this side effect. But it's still a miraculous drug because this patient before couldn't take Cinnamon. She couldn't take Cinnamon because a little bit of Cinnamon would make her completely delusional that her family was trying to poison her, to kill her, all kinds of things. So she needed this antipsychotic drug that didn't block dopamine receptors, and she could take amounts of Cinnamon that allowed her to function normally. Now she takes care of her grandchildren. She's not, quote, psychotic. So it's amazing. It's amazing. I also used that Clozaril when it first came out in one of the members of the board of trustees at the University of Miami. And it was like amazing. He was completely transformed. He no longer was delusional, paranoid, psychotic, and he was able to function and take Cinnamon in the appropriate level. So what do we use now? Clozaril is still the best one, but it's a hassle. No one likes to get stuck every week for a blood test. So the next one that came out is called quetiapine or Seroquel. Now Seroquel is just as effective, maybe not quite as good, but it prevents hallucinations and psychosis. It's another one of the novel tranquilizers. It doesn't block dopamine receptors. And so we can use it to treat Parkinson's disease patients who have hallucinations or confusion or serious insomnia with acting out of dreams. So I have many people, instead of using sleeping pills, which only work for about a month, I put them on Seroquel at tiny doses. The doses that we use to treat schizophrenics with Seroquel is 900 milligrams a day. The doses that we use in Parkinson's disease patients to help them sleep without vivid dreams and without hallucinations is 25 milligrams. Think of it, from 900 milligrams for psychosis in schizophrenics to 25 milligrams at night for a patient with Parkinson's disease. So for me, it's much better than any of the classic sleeping pills that are all benzodiazepines, all Valium related, that worsen depression, have become tolerant, and cause dependence. So the number one drug of abuse amongst people over 60 in the United States are the benzodiazepines, the Ativan, the Valium, the Libriums, the sleeping pills. And that's the number one reason that people overdose. It's from those drugs. So you don't see me prescribing those very often. You can't really overdose on Seroquel. And you take such tiny amounts of it. So those are the two major problems that confront patients with Parkinson's disease and their doctors, because the complex motor fluctuations end up a certain fraction of them requiring surgery, and then the psychological and non-motor symptoms, insomnia, can be very difficult to manage if you're not familiar with Seroquel. Now, with all of the major tranquilizers, there's a black box warning. So if you read the little fine, get your magnifying glasses out, it'll say people who take any of the major tranquilizers, including the new ones, like Seroquel, Clozaril, have a higher risk of dying. Of dying. The older you are, the more likely. So they say, be careful with your elderly, demented patients, because you're going to increase the risk of death. That's what it says. And it's either, you know, and the fact is, I don't know where that comes from, but I guess they do this post-marketing. And I don't know, but just to be aware of that, even though I'm very positive about the use of Seroquel, I'm very judicious. I don't allow it to be used in very high doses. I'm afraid that if it's used in too high a dose, maybe it's true what the FDA requires. But imagine if we didn't have these drugs, Seroquel or Clozaril, many of our patients would be rigid and akinetic because we wouldn't be able to use Sinemet. So that's what we are always weighing. The positive versus negative effects, the beneficial versus adverse effects. So the beneficial effects are huge with Seroquel and Clozaril. The negative effects that I've seen is excessive somnolence the next day, and that can be adjusted. And there's a warning of negative effects that's in the fine print, that it can increase your risk of stroke, of death, etc. That is required by the FDA to be put on the insert. So now I'll take some questions.
What would be a startup?
Well, he raises his hand a fraction of a second sooner.
Now, the rule of thumb is you don't take your medication a half hour before or a half hour after eating food because it doesn't digest as well or get coordinated as well. Does that pertain to Apigen too, since it's subcutaneous and shot in the...
No, and this whole thing about when to eat, when to take the medicines in terms of what and when you eat has only to do with the natural drug, which is levodopa. Levodopa is a natural substance. It's found in all protein, okay? Levodopa is one of 20 amino acids. And amino acids are the building blocks of protein, and proteins are your entire body, and also enzymes that operate the machinery of the body. So what happens if you have a meal that's rich in protein is that the levodopa that is in the pill Sinemet has to compete with the other amino acids of that protein in your meal for entry into the brain, because even though proteins and amino acids are essential for life, without them you're dead, the access to brain is very regulated. In fact, there's a blood-brain barrier, and there are little gateways from blood to brain. One of the gateways is called the neutral amino acid transporter. It's a little channel into the brain, and levodopa uses that channel. And it's a limited amount that it can be transferred from blood to brain. So if you eat a meal and you're digesting just a glass of milk has a ton of neutral amino acids. It takes 2 hours of circulation of digestion before those amino acids are metabolized. So for the 2 hours after eating, you're going to have the dopamine, the neutral amino acid transporter clogged up by all these other proteins being used, so that the levodopa you took around the time of eating, either a half hour before or a half hour later, or an hour later, it's going to have a harder time getting into brain. That's why many people will notice after a big protein meal, for the next 3 hours, it's like they're off, even though they took their usual dose of Sinemet, even an hour before. Even an hour before, because this is a very gradual process. So you take something into your mouth, gets into your stomach, it's dissolved, and then from the small intestine it gets into the blood, it goes through the liver where it's metabolized, and from the liver it finally gets into the general circulation. All that takes time. But so let's say, here's the best example of how this works. If you were to administer a meal, let's say rich in protein, either by mouth or even better, you can give a solution, intravenous solution of all the neutral amino acids. This was research done at NIH. And you can, in the other vein, give levodopa intravenously. So you bypass the whole gut and stomach and liver.
Right.
So, and you have someone who's completely off, and you look at their finger tapping speed. And when they're off, they can barely do that. Then you turn on the drip for levodopa. within 5 to 10 minutes, their finger tapping speed is normal. Then you turn on the other intravenous drip, run in the neutral amino acids. Within 5 to 10 minutes, they shut off. They can't do that anymore. That's how quick that's the action at the blood-brain barrier. So that's why it's only with Cinemet that protein and meals have any impact. When you take a dopamine agonist, it is not being transported by the neutral amino acid transporter. These are very fat-soluble chemicals, and fat-soluble chemicals can get across the blood-brain barrier right through membranes. They sneak right in. They don't need a special channel. And most drugs that we give tend to have to be able to penetrate the blood-brain barrier, but you want them to act centrally. So that's why the Apocrit, the ropinirole, the Mirapex, doesn't matter about the meal. However, most people are taking Cinemet with those, and they'll notice the difference after a meal, not because Mirapex or Pramipexole or the Nupro patch is impacted by the meal, but the levodopa is definitely impacted. Now, in the beginning of the illness, it doesn't really matter because all you need is a little bit of the levodopa to get into the brain. Because you still have enough of the dopamine storage capacity, you still have enough dopamine neurons that you don't rely exclusively on the pill to load up your dopamine storage in your brain. But only with time, as you lose more and more dopamine neurons, does your clinical response depend on levodopa getting across the blood-brain barrier. And therefore, later on in the illness, meals and protein content do have an influence on whether you're going to be on and off for hours after a meal. So there's another question here.
What's the startup for carbidopa, levodopa? What would be the milligrams to take? What would be the startup milligram that you would
you have
take?
to tell me, is it someone who was diagnosed at the age of 60, diagnosed at the age of 40?
80.
That's kind of late. So someone who's diagnosed at the age of 80, let me tell you, I would have my doubts that it's Parkinson's disease. If you're diagnosed at the age of 80, and it began with a gait problem, with the arms kind of loose, it's lower body Parkinsonism, and those people probably won't have any benefit from Cinemet. But let's assume it's a 65-year-old who's had Parkinson's symptoms since age of 60, but now the symptoms are troublesome. He needs symptomatic relief. That's a better example. 80-year-old starting Cinemet, I'd wonder. I'd wonder if this really is Parkinson's disease at all. It may be called microvascular Parkinsonism. But so how you start with Cinemet? It usually says take 1 3 times a day. And I always say start with a half tablet at breakfast and a half tablet at supper for 3 or 4 days and see what it does to you. Some people are extremely nauseous with just that half tablet. So that's why I start with a very low dose. Cinemet lowers blood pressure. So that's why I give them a low dose to make sure they're not lightheaded. If they have no side effect, they notice, I don't expect they're going to be better with that dose. This is kind of giving them a trial to see that they can tolerate it. Then after 3 days, you give them an extra half tablet. So that's at lunch. So it's breakfast, lunch, and supper, a half tablet. Then after 3 days, I say, this is the general rule, and most people are not able to figure this out, no matter how well educated they are. I say increase by half tablet every 3 days. So by that I mean a half tablet per each dose every 3 days. So what that would mean, and I'd write out 1 tablet at breakfast, a half at lunch, half at supper for 3 days. Then after 3 days, remember it's a half tablet, you add that other half tablet at lunch, not at supper time as well. So the next 3 days, 1, 1, and a half. After 3 days, add another half tablet. So it's 1 at breakfast, 1 at lunch, 1 at supper. And usually write that out on a piece of paper and ask you to put it on the calendar. So that is the usual titration regimen when you start Cinemet. And you observe then for 1 tablet 3 times a day for a couple of weeks to see if the symptoms are better or not. If they're still not better, I will say, well, try it at breakfast without any protein to see if it's just that all the protein you're eating is what's interfering with access. But more often than not, I'll say you can continue going up by a half tablet every 3 days until you get benefit. So then I would say 1 1/2 1 and 1 for 3 days, 1.5, 1.5 and 1 for 3 days, 1.5, 1.5 and 1. Usually 1.5, 3 times a day in the early stages of illness is sufficient. Some people need to end up taking a 4th dose, so I'd say 8, 12, 4, and 8. Start with a half tablet 4 times a day and build it up by half tablet more every 3 days. Now, some people, let's say you're taking 1.5 tablets 4 times a day and you're doing well, but you want to try a little bit more to see if the mornings can be more, you can be more mobile. So you take 2 in the morning, 1.5, 1.5, 1.5. And that morning you feel nauseous and lightheaded. So what you do is you go back to the previous regimen of 1 tablet, 1.5 in other words. So it's a staircase you're climbing. And when you have an adverse effect, you just don't jump to the ground floor. I've had people do that. Some people just say, I can't take Cinnamon, doctor. I get so nauseous and sick. I've never been able to take it. So they're in the most advanced stages of illness because no one has had the patience to start off with a 1/4 tablet a day. You can take a poison that's going to kill you if you start it with a tiny dose first and build it up. That's, you know the story of Rasputin, that crazy monk. They were putting arsenic in his wine, trying to do him in. And the maid that they had paid to do it would put in a little bit more arsenic every few nights. And after a while, she couldn't dissolve enough arsenic in the wine without it being visible. So he became very rosy-cheeked and healthy looking because arsenic kind of gives you a red complexion. He tolerated a poison because she did this gradual titration. So people who say they can't tolerate Cinnamon means that their doctor has not had the patience to write out a schedule, starting with a 1/4 tablet a day for a week or 2 weeks before you add to the other 1/4 tablet. And then eventually, even the most finicky patient can take an adequate dose. But I've had people who, like that, they finally get to 1.5 tablets 3 times a day without adverse effects. The husband says, wow, I can't believe she's actually taking it. She's so much better. Then they go up to 2 tablets in the morning, 1.5, 1.5, and she says, oh, I felt so sick. This is the worst thing I've ever experienced. I'm not taking this anymore. It's like jumping from the 3rd story of her apartment building to the ground floor suddenly. What you do is you go down the step, but you didn't do that. But that happens. So the idea is gradual upwards and gradual downwards. That's what everybody who starts Cinnamon should be. What the worst mistake is that private practitioners will say, okay, you have Parkinson's here, take 1 3 times a day. Because that's the standard. That's usually sufficient. But some people can't handle that dose. Why do you think that levodopa and all of these dopamine agonists make people throw up, nauseous? The reason it's called Cinnamon means it was no vomit. Because I tell the story, I'll tell it again because everyone forgets. And if you want to remember something, you have to repeat it a lot. Levodopa is a naturally occurring amino acid. And when it was found that a natural dopamine transmitter was very low, we knew from the biochemistry of many of the amino acids that levodopa is the building block, the material from which dopamine is made. So that led to studies of levodopa administration as a nutritional supplement almost, where 8 grams were eventually taken. Tablespoons amounts of levodopa were given, but initially you started with a teaspoon a day, and you gradually increase it until, the reason you did that, because as soon as you took that levodopa, you threw up. And the reason that happened is that levodopa, when it gets into the liver and in the intestine, is metabolized by something called decarboxylase into dopamine right away. Now dopamine is charged and can't get across the blood-brain barrier. Only levodopa can get across the blood-brain barrier. So dopamine could get right to the blood-brain barrier where there's a little area called the chemoreceptor trigger zone that is sensitive to dopamine, and it causes vomiting, instant vomiting. So that people who took levodopa would end up getting nauseous and vomit. But with time, tolerance develops. So people didn't get as nauseous, and they were able to take 8 grams of levodopa per day and get up and start chasing the nurses from where they were, from their wheelchairs, because this was what the awakening story was. The first trials of levodopa was pure levodopa, not carbidopa levodopa. So only a small subset of patients could take levodopa in that way because they have, quote, stronger stomachs. They develop tolerance to the nauseant effect. So it was discovered why the nausea was happening. And they found, what if we prevent levodopa from being metabolized in the liver and the gut by putting a material that looks a little like levodopa that occupies that enzyme, liberating levodopa to penetrate the blood-brain barrier. And that's what carbidopa was. It's a slight variation of levodopa. It ties up the decarboxylase enzyme that converts levodopa to dopamine. Therefore, you're not getting dopamine in the outside of the brain. Allows levodopa to get into the brain, where there it is transported from blood to brain, taken up by dopamine neurons and made into dopamine, and then voila, you can move again. So what carbidopa levodopa did was called levodopa without vomit, right? And how do you say that in Latin? Sin emesis. Emesis, vomiting. Anti-emetic, anti-vomit. Sin emesis means without vomiting. So if you wanted levodopa without vomiting, you took Cinemet. That was the brand name. Just change the S to a T. And that was why I tell people, if you're getting nauseous from Cinemet, good thing that we're already way ahead of your ball game because we don't use levodopa anymore. You shouldn't be so nauseous. But nevertheless, some people are still quite nauseous. What about all the synthetic dopamine? We have three that we use: Requip, Requip, Pramipexole, and Rotigotine, the Nupro, the Mirapex, and the Requip. They all act on dopamine receptors, and so they all can cause nausea. Because even though it quickly gets into the brain, there's some tickling of that chemoreceptor triggers on the dopamine receptor that causes vomiting. That dopamine receptor is not in the brain, it's right at the blood-brain barrier junction. Any more questions?
Comtan, how would you classify that?
Comtan? What Comtan does, it's another enzyme. It inhibits an enzyme that metabolizes levodopa and dopamine. So levodopa is immediately metabolized in the gut and liver by what's called peripheral decarboxylase. It gets rid of a CO2 and makes dopamine. Dopamine then can't get across the blood-brain barrier. It's metabolized further by two enzymes: monoamine oxidase and catechol-methyltransferase. MAO inhibitors we give all the time. Selegiline and rasagiline will inhibit the breakdown of dopamine both in the body and in the brain. So that's an MAO inhibitor, and we use those. COMT is a drug that inhibits the breakdown of dopamine in the gut and in the liver. And that's what the COMT then allows for a longer duration of action of levodopa because you're inhibiting some of the breakdown of the levodopa with another enzyme inhibitor called COMT inhibitor, that's Comtan, entacapone. Now for convenience, levodopa carbidopa, which is called Cinemet, has now added entacapone to it, and that's called Stalevo. So now you got three drugs. One is the natural precursor, levodopa, and the other two drugs are inhibitors of metabolism of levodopa and dopamine. So you have the carbidopa and the Comtan. So instead of taking 3 pills, you take 1 pill, so it's convenient, and that's what Stalevo's about. Other questions?
Back there, that way, back.
Well, okay.
Back to the cinnamon and timing. When you say rich in protein, how many grams of protein are you thinking is rich? And does that make a difference as to the weight of the patient?
Yes, it does. And the way I look at it is this, that you can't really cut back on protein. People tend to lose weight with this illness. You need to really, especially if you're diabetic, you can't start taking more sugars. The optimal ratio should be 7 parts carbohydrates to 1 part protein, is what people have told me. And there was actually a company that made a diet specifically for Parkinson patients that allowed for a low amount of protein in your diet 3 times a day. The weight is obviously important because you probably need more levodopa the heavier you are, and you probably need more protein the heavier you are. What I do is, if you want to consult a nutritionist, that's fine. But what I say is, if you want to see if protein is responsible for the off period that occurs after meals, try no protein for that meal for a whole week. what I like to do is say, try the lunchtime dose. And for lunch, have only a vegetarian meal. And by that, I mean no animal products, and no beans, and no soy milk either. So it's not truly vegetarian, but the idea is it's salads, breads, fruits, vegetables, no chicken, fish, eggs, cheese, milk. Do that at lunch and observe from lunch till 3 or 4 in the afternoon. If you see that the benefit of Cinemet is much greater with that no protein, then you can start experimenting. Because the nutritionist's advice is, I think, not going to be that easy. It's better for you to try it. And the principle is that the higher the protein content, the more advanced the disease, the less levodopa is going to get into the brain following that 3 hours of digestion. So and typically I wouldn't worry as much of diet, then you just have to rely much more on the dopamine agonist that isn't affected by diet. There's another question.
Joyce tried a Nupro patch. What the Nupro, it's the patch that causes the problem. If she can't take patches, is there another way for Nupro to work besides using the patch?
Well, Nupro, the whole purpose of the Nupro is it's a special molecule that is ideal for penetration through the skin. There is no oral, there's no oral version of rotigotine. And it wouldn't be any more advantageous than extended release Requip, for example. Requip comes extended release. That's what I would do if you can't take the patch. But most people, unless she breaks out really seriously and gets blisters,
the rash.
The rash is not too. What you do is you don't go to that. Take the patch off, and you put 1% steroid cream. It's over the counter, cortisone, and put that for 2 or 3 days. And you're not going to go to that same site for another 10 days. And so a little rash is not unusual. When it's a breaking out with blistering, then you're allergic. But a little itching, especially people say, I start itching about 2 hours before it's due to come off. You know, what I always recommend is you treat that rash the moment you take that patch off. You put 1% steroid cream twice a day for 3 or 4 days, and you'll see that you'll be able to tolerate that patch. There's a lot of people say they can't tolerate it, but they really can. It's only those that have a serious skin eruption from it that I would worry about.
Is there a correlation between a vitamin D deficiency and Parkinson's?
Yeah, there seems to be more and more of this, that vitamin D3 is more likely to, if you're deficient chronically in it, you're more likely to develop Parkinson's disease, as well as dementia, heart disease, everything else. So it's just good for health. I don't think it's directly related so much to Parkinson's disease as a health issue.
One end stages I came across, and I didn't quite understand. Is that pertaining to Cinemat, the end stages? Is
Well,
it before then, four stages?
Well, it's hard to say what you mean by end stage. No one really talks, I guess end stages is where you might need hospice because you can't swallow, you're so rigid akinetic, and the Cinemet doesn't work at a really advanced stage of the illness. It's still some relief. If someone has Parkinson's disease, then let me go over the staging. There's really the staging that is devised by Hone and Yar. It's pretty crude. Stage 1 refers to the fact that the findings are initially just on one side of the body. It's very, very unusual and not typical for Parkinson's disease to begin on both sides of the body at the same time. That's why people say that an 80-year-old recently diagnosed, they usually began with the gait, and they don't have an asymmetry. That's not typical for Parkinson's disease. So stage 1 is one-sided symptoms of slowness of movement, rigidity, or rest tremor. It may be noted as decreased arm swing. This might be all you see. Everything's okay, except this arm is not swinging. That's stage 1. Or you might see this, stage 1, that's it. Everything else is fine. Stage 2 is now the symptoms are on both sides of the body. but one side is always more advanced than the other. And people always, why is that there that asymmetry? It's because the levels of dopamine on each side of the brain are not the same. Even in mice, if you were to measure dopamine concentrations in the right and left striatum, it's never the same in a given mouse. On the average, if you take 50 mice and you take all the right hemispheres and all the left hemispheres, the levels will be equal. But in any individual mouse, you'll see one, and same with the human brain, one side of the brain has more dopamine than the other side of the brain. So the side of the brain that starts off with less dopamine is the side which will deplete quicker, result in contralateral symptoms, because the left brain controls the right body. So left dopamine being low from birth, you're going to have symptoms on the right. And it has nothing to do with handedness. And it's a 50% probability whether it's going to be one-sided, right or left side at onset. Eventually it's bilateral. And the third stage, hone in your third stage, is when people begin to lose their balance. They're not falling, but they notice they're a little bit less steady on their feet. They might have a little harder time recovering, but they don't fall yet. Stage 4 is they're actually falling. And at stage 4, they should have some kind of assistive device. Well, they don't fall all the time, but they can fall occasionally. And to prevent these falls, a walker or a tree or a cane, with the advice of a physical therapist. Stage 5, which is the last stage of the illness. I don't like to say it's end stage because it's not. I have many people in stage 5. Means that they can't ambulate independently. Even with a walker, they can fall. Unless someone's kind of accompanying them. They can maybe transfer a short distance with a walker, but most of the time they have to use a wheelchair. So, or they're unable to ambulate independently. That's stage 5. They still, at stage 5, if they responded to levodopa, still have less rigidity and slowness when they take levodopa. But since the illness involves so many other parts of the body, so many other systems that don't respond to dopamine, that accounts for a lot of the difficulties that we see. So there's this autonomic nervous system that is involved with this illness. So the constipation, the urinary frequency, the feeling hot and cold, tingling, aching, and a component of swallowing and bladder control is related. Now, those are two things that you think you can control, right? You can choose to swallow, because there's a voluntary aspect to swallowing. But then there's an automatic reflex of swallowing. It's mediated by smooth muscles in the complex symphony of swallowing, right? Well, that becomes limited because of the autonomic nervous system involvement, just like the gut is limited. The upper part of your digestive system is your swallowing. It starts up in the mouth. And because there's a difficulty in swallowing and clearing secretions, people develop aspiration pneumonia. And that difficulty in swallowing at a certain stage is not made better by Sinemet or dopamine agonists or any drug. So that I would call end stage, when people are now developing aspiration pneumonia every month, right? And that's what takes people away to meet their maker. Usually a silent pneumonia where they don't wake up the next morning. That's a graceful death. The other thing that takes people away is a fall with a hip fracture, surgery, complications, spiraling down in the hospital. So those are, I would say, end stages when you develop recurrent pneumonias, and you might do better with a feeding tube, but then there's the ethics. Do you really want a feeding tube? Or the falls. So those are things that don't respond to Sinemet. I hope the answer. You still get less rigidity and slowness with Sinemet, but it won't improve your swallowing necessarily. The voluntary aspect of swallowing can be improved, but the involuntary aspect is not improved. We don't understand how to improve that. There are the vital stim devices you put on the throat. I have barium swallow studies, and swallowing experts come and evaluate you. Sometimes they can make a difference by changing what you eat, decrease the likelihood of aspiration pneumonia. So the two biggest, challenges in advanced illness is how to improve autonomic nervous system function. because we don't really understand how to do that properly. And it's because of that that then people develop pneumonia, aspiration pneumonia. And the gait and balance problem doesn't respond to dopamine at this stage. But we're starting to learn something about the neural systems that allow you to walk automatically and prevent falls. So I think there's hope for both of those. Now let me remind you that before levodopa, people with Parkinson's disease didn't live very long. Since the introduction of levodopa, since the 1960s, people's life expectancy is roughly the same as someone without Parkinson's disease. So, but the quality of life suffers, obviously, because in the advanced stages of the illness, there's a loss of independence. But there's all kinds of ways around it, and that's what this Parkinson Place is all about, to kind of help you navigate for the non-medical aspects. So I'm going to end here because
Thank you.
We thank Dr. Lamont.